Hey there. Good afternoon or good evening, as the case may be. It is 4 o'clock straight up in the mountain time, which means 6 o'clock on the East Coast, three on the West. And my name is Dr. Randy Fink. Welcome to Fertility with Fink and Friends. I am Fink. You are friends, and we are live from the beautiful city of Colorado Springs, where I am the clinical director of IVF services here at CNY Fertility. We have locations, gosh, I won't say all over the map, but in several places around the map. So, Syracuse, Buffalo, Albany. We have a clinical location in Sarasota. We have a monitoring center in Rochester. We have our office here in Colorado Springs. We have a monitoring center in Atlanta and a monitoring center in Norfolk, Virginia, that's now also doing IUIs, I'm told, and are well on the way to being part of the full service IVF CMY family. So I hope Tuesday afternoon is your favorite time of the week, because it is pretty much my favorite time of the week to get to be here with you guys. I love this opportunity that we have together, and I cherish the time we spend and cherish the folks who come to join us every Tuesday afternoon at this time. So let's say hello to who we have here over on the Facebook and YouTube side. Looks like Neri Millie. Nice to see you. Good afternoon. We've got my Instagram over here, which is Randy Fink MD. My very special friend Angela is here from Minnesota. Amy Jenkins, of all people, is with us. The former, well, my former friend, Amy Jenkins, who left us in the dust to go and serve her country and is now gracing the streets of Washington, D.C. That actually doesn't sound very nice, does it? Gracing the streets of Washington, D.C. I think she spends relatively little time on the streets, relatively. But Amy used to be our nurse practitioner here. We've got Brandis has joined, who is our nurse practitioner at CNY in Colorado. Hi to Grace and Brock. Nice to see you guys. Melissa, Bubbles, Ruzik Blue from the wonderful city of Las Vegas. Hello. Amazing Javier. Great to see you. Miss you too, Mrs. Jenkins. And here on the CNY Instagram side, looks like Samagram was our first to join, so a special shout out to you. Melissa's here. Georgia is with us. Sid Glow, Crystal Haybor. Hey, happy to see you too. That Boogie RT. Hey, nice to see you. Sandra Nail Artist. I was going to say Sandra Narcissist, but that's not what that says. Sandra Nail Artist. Abby Kadabi 88. Oh, good. You're going to be here in a couple of weeks, and we are looking forward to having you. Katie Baby. Hi to Taniani. If I said it correctly, April. The Meg Johnson, initial consultation on Thursday. Great, fantastic. Corey Wells, Ash Abrams, all kinds of nice folks here. Melanie, Mabel, Mabby Mal, May, I'm sorry, I tried. Tintin J. Bullock, Melanie Marie, oh my goodness. Melanie just had a hysteroscopy with Dr. Chang in CNY, excited to take the next step. Good deal. Hysteroscopy is a little procedure where we look inside the uterine cavity with a camera in order to make sure that the uterine cavity looks normal. Why do we need to do that? Well, once a year, we want to evaluate the inside of the uterine cavity to make sure that there is that there are no polyps, that there are no growths inside the uterus, scar tissue, bands of muscle, fibroids, things that can otherwise interfere with your beautiful little embryo from being able to implant. So hysteroscopy was done today, Melanie. That is awesome. A special hello also to Allie Bright, joining from Minnesota. Gosh, it's a good day in Minnesota, actually. And I'm told in Minnesota it was warmer than it was here. Well, it's actually 71 degrees today. I think it's finally going to warm up a little bit. But Colorado gets a little schizophrenic in terms of weather at this time of year, that it can be real cold in the morning and, beach weather in the afternoon. I want to talk. We're going to absolutely get to all your questions here, but a couple of things I wanted to talk about to begin with, just to throw a couple of things out there. And the first has to do with intra-ovarian PRP. PRP. What is PRP? PRP is platelet-rich plasma. So Mother Nature is bipolar, says Melissa. You are absolutely right. Um, if you've ever heard of PRP, so they use PRP in a variety of different scenarios. It is used in aesthetic medicine. It's used in orthopedics. It can be injected to an injured joint. It can be used as facial filler. It can be used to help you regrow hair where hair is missing. In the fertility world, we use it as what is colloquially called ovarian rejuvenation. What is ovarian rejuvenation? Well, I mean, the truth is, it's not really a term. It's not a thing. It's a term that's sort of coined by the internet and social media. Medically speaking, ovarian rejuvenation doesn't really mean anything. But if you took a tube of blood and you spun it, you put it in a centrifuge and you spun it down, maybe you've seen what happens to it. The red blood cells go to the bottom of that tube. I was going to say, do I have one of those tubes around here? I don't see it right now. Red blood cells go to the bottom of that tube, and there is some liquid at the top that's called the plasma or the serum. Normally, the platelets, which are a portion of your blood that are usually used for clotting to stop you from bleeding, platelets have with them some special features. They're what we call your growth factors, your healing factors, your tissue factors. It's the most healing part of your blood components. Normally, when you spin that blood down, the platelets fall down with the red blood cells. And when they fall with the red blood cells, it's hard to really do anything with those. Well, with PRP or platelet-rich plasma, the magic is in the tube itself. That there's a medium in the middle or media, I should say, in the middle that keeps the platelets in the plasma part, so that we can actually separate out those growth factors and can place them back inside of you, place them back inside the ovaries, and that's what's known as intra-ovarian PRP. What does it do? Well, it's still considered experimental, so we don't really know 100% what it does and whom it most benefits, when to use it, how long the effect lasts. But people with issues regarding egg quality will frequently use intra-ovarian PRP. It's a procedure that takes, about a minute or so. We do it under some anesthesia so that nothing hurts. By ultrasound guidance, we place a little needle into the ovary and inject some of your own healing components, your tissue, your PRP, back into the ovary, which has probably several effects. It causes some remodeling of the tissue in the ovary, and it helps to create some new blood flow to the ovaries. It rejuvenates the ovaries, as it were. Intra-ovarian PRP is becoming a more popular thing to do, and I'm doing cases of intra-ovarian PRP here now in Colorado, probably just about every day of the week. I think it's a great procedure to do, although, again, there's so much about it that we don't know yet, things that we're still striving to understand. But if you're in the situation where your ovarian reserve may be lower than expected, or goes hand in hand with that, the egg quality, the stability of the DNA within those ovaries may not be what you hope, then using some of your platelet-rich plasma in the ovary may be something that makes a big difference in your story. I think we're probably going to do an Instagram post on PRP in the coming week or so. So keep your eyes peeled for that. But I just wanted to talk a little about PRP because we're doing so much more of it that it really is becoming more of a mainstream type procedure and a treatment that we can offer you to help with your outcomes. Let's see a special hi to Ashley Carbonell over on the Facebook side. I really want to go to CNY Colorado because logistically it's closer, yet I'm having an issue understanding that Cooper Genomics is not within Colorado. How do you guys send the egg, sperm, embryos to and from the lab with minimal loss of embryos? How does this work for your clinic? Not sure what you mean there. Oh, you mean that Cooper Genomics is not located in Colorado? I think they're located. Actually, I can't remember where they're located. But basically, so what happens with PGT? Pardon me. What happens with pre-implantation genetic testing, Ashley, is that we grow the embryos. Well, eggs come from you. We have partner sperm. One sperm goes in each egg, and that makes an embryo. Those embryos are grown up to a certain stage, which is called a blastocyst. A blastocyst is typically a day 5 embryo, but sometimes day 6, sometimes day 7. The cells are biopsied. They're cells from the outside portion of the embryo, that which is called the trophectoderm. The trophectoderm is what becomes the placenta. So it's not actually taking a piece of the baby. So you don't have to worry that we're biopsying off your baby's arm or anything like that. We are taking a piece of what becomes the placenta. Those cells get frozen. The embryos themselves get frozen and the embryos stay here. The portions of the cells get sent to Cooper Genomics, and in 10 to 14 days, we get results back from the PGT. So the genetic testing, we're able to determine which of the embryos are believed to be chromosomally normal. That is to say, is the placenta part normal in that embryo? Now, there can be some discordance between the baby itself and the placenta, which is why the testing is not perfect, but it's the best we have. If you have one chromosomally normal embryo, that gets you a 65% probability of pregnancy. So that's the highest odds we can expect with IVF. By the time you get to if that first one doesn't work and we get to embryo number 2, you're at an 88% chance of pregnancy. If the second one doesn't work, then by the time we get to embryo number 3, you're at a 95% chance of pregnancy. So clearly, a tested euploid embryo or a chromosomally normal embryo is the best kind of thing that we can hope for in terms of outcomes with IVF. So the embryos are frozen, and when we get the report back, you come back and you do a frozen embryo transfer, which is where we thaw the embryo and place it back inside of you at just the right time. The survival rate on an embryo thaw is about 97%. So 3 out of 100 embryos will not survive the thaw, but it is generally a very, very good and very high success rate with embryo thawing. That technology has come a very long way, even in the last 10 years. The process of freezing an embryo is what's called vitrification. And what they do there is they're able to take all the water out of those cells. And if you take the water out of those cells, well, if you leave water in the cells, then it forms an ice crystal, and that ice crystal inside the embryo can damage the embryo. So come really a long way with that. But hopefully that answers your question there, Ashley. Where the embryo gets sent should not be a concern, or because I shouldn't say where the biopsy gets sent geographically doesn't really matter because the embryo is staying right here. Allie, again from Minnesota, says, I hope I'll be seeing you again this Friday or next Monday for an FET. Labs tomorrow. We have 3 embryos retrieved last month. Our fresh transfer wasn't successful. Fresh transfers are never as successful as frozen transfers, so your odds are going to be much better coming back for a frozen embryo transfer. We have 2 left. I'm 30, have a low AMH and a tubal blockage. Would you suggest transferring one or both of these day 3 embryos? Well, in general, I would suggest probably one of them, because at 30, there's a pretty good probability that you're going to create chromosomally normal embryos. Putting 2 embryos in really increases your risk risks with pregnancy, but doesn't so much increase your live birth rate at this point. So, and the fact that, you talk about some embryo grading there, the grading doesn't so much correlate with outcomes either. So if it were me, Allie, I'd probably recommend one embryo at this time. Let's see. We'll go back over to my Instagram side here, and that's Randy Fink MD. And Pink Butterfly is here. Hi to Karen. Hello to Super Alexis Lorente in Miami. Rusic Blue in Las Vegas says, can you tell me about an ERA? Do you recommend it? I've had several failed transfers and tried everything I can except for the ERA, Emma and Alice. All right, so the ERA stands for endometrial receptivity assay. And this sounds like it's a great idea, but it's not. All right, I'll preface it with that. There are very few scenarios now where I would recommend an ERA. There may be some more important things there, Rusic Blue, like the use of Prograph in your transfer. Prograph helps your body to prevent. Helps you to prevent your body from treating your embryo like it's an invader, like it's a solid organ that you're replacing, like transplanting a kidney that you're trying to reject. When using Prograph at 3 milligrams per day, which is 1.5 milligrams twice a day, or you can do 1 milligram 3 times a day, there's a very dramatic effect in increasing the odds of an ongoing pregnancy, especially in someone who has had recurrent implantation failure. So I would say that's probably the most important thing for your cycle there. Probably the second most important thing is testing for endometriosis. We know that endometriosis can stand in the way of even a perfect chromosomally normal and beautiful embryo from sticking inside your uterus. How does it do that? Well, it confuses the way the brain is talking to the uterus. The brain's telling the uterus, implant that baby. But if the uterus is hearing blah, 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 then it doesn't know what it's supposed to do. And that's kind of what endometriosis does. Would you like for me to repeat that in case you didn't get it the first time? Blah, 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 blah. That is what the uterus hears when there is endometriosis. So endometriosis changes the lining of the uterus and causes you to create an inflammatory marker. And that marker is called BCL6, highly associated with endometriosis. And when that inflammation is present, it can take your perfect embryo, which was right, we said that PGT tested embryo, 65% chance of pregnancy. It can take that 65% number and drop that number to less than 10%. So you go from 65 in 100 to about 8 in 100 of those embryos sticking because of the endometriosis. We can test for the endometriosis with a test known as Receptiva. Receptiva is an endometrial biopsy. It used to be that endometriosis we could only diagnose through laparoscopy. My personal feeling is that if you can save yourself a surgery, don't do the surgery. Do a non-invasive test that very highly correlates with endometriosis. If the BCL6 test is positive, then we treat you for 60 days with some medication, either Lupron or Alyssa or Myfembree, and that dramatically increases the odds of pregnancy. Now, the ERA, endometrial receptivity assay, was predicated on this idea that we all have a very narrow window during which we can implant a pregnancy, and that in 75% of us, that number, that time period is exactly the same, which means that in 25% of us, it's not, it's different. So the thought was, well, we need to see if you are in the 25% as opposed to in the 75%. And if you keep having transfers and it's not working, we got to check your timing. Doesn't that make sense? Well, yeah, it kind of does make sense, except that it turns out that that's not really the case. When they studied this in great detail, looking at tens of thousands of cycles, they found that it doesn't really matter what your timing is, that our window of implantation is really probably a lot wider than we thought it was. We thought it was kind of plus minus 3 hours. That's when the embryo had to get to that lining, or else it wasn't going to work. Now we know that that's really probably not true. Again, tens of thousands of cycles, they looked at it and they found that didn't really make a difference. That whether your timing was early, whether your timing was late, or whether your timing was right on time, it didn't change the pregnancy rates. So this idea of the ERA that used to be a very standard part of what we would do to evaluate when things weren't working the way they're supposed to, now really I would consider in most cases, not all cases, but certainly most cases, to really be an unnecessary test. And it's not inexpensive either. The Emma and the Alice test go hand in hand. Visual. They go hand in hand with the ERA. So they call that the endometrio, the ERA, the Emma, and the Alice. The Emma and Alice are designed to test what is said to be the microbiome of the uterus. Well, what part of it is doing is actually just sort of testing the vagina, which hasn't really been shown to make a big difference. And then the other part is looking to see if there is some inflammation or chronic inflammation like endometritis in the uterine lining. Well, as it turns out, there are cheaper ways to do that. In that Receptiva test for endometriosis, which is a very valid test, we can actually do a test for chronic endometritis. Even in a regular endometrial biopsy, we can test for endometritis. So that is perhaps useful. But Ruzik, I don't recommend really the ERA anymore. So in your situation, I think Prograph, I think endometriosis, those are two really important things. And I think the list of supplements that we often talk about here, by the way, supplement-wise, I do have a book that I wrote on the evidence-based protocols for egg quality and embryo transfer, for sperm quality. That book is only $7, and it actually comes with a discount on a group of supplements. You can get to that by my link tree, which is linktr/EE, Randy Fink MD, or it is the link that is in my bio on Instagram, which is Randy Fink MD. I will also say that Molecular Fertility, molecularfertility.com, has a wonderful group of supplements that I also strongly recommend. So 5 supplements are important for embryo transfer: your prenatal vitamin, vitamin D, vitamin E, CoQ10, and L-arginine. L-arginine is not used for egg quality. It can diminish egg quality, but for embryo transfer, very important, those 5 things. So I think everybody should be on those 5 things if you're planning to do a transfer. So hopefully that is helpful there. Laura Marie says, a functional med doc put me on low-dose naltrexone for Hashimoto's thyroiditis. The fertility doc doesn't seem comfortable to keep me on it. Doesn't seem to know much about it. Should I push to stay on it for IVF? Well, I will tell you that at CNY Fertility, almost everybody is on low-dose naltrexone, typically 4.5 milligrams once a day, both through the stimulation portion of the cycle and for embryo transfer. Many doctors are not comfortable with it because they don't know enough about it. It increases your endorphins. It decreases inflammation. What you have there with Hashimoto's is an inflammation in the thyroid gland, or what we call autoimmune thyroiditis. And that is an immune response against your own thyroid gland. What does that tell me? Well, we try to keep your thyroid hormone in a particular range when you have Hashimoto's, the TSH number, which we want to keep everybody in a particular range. We want to keep everybody between 0.5 and 2.5. With Hashimoto's, I like to keep it closer to about 1.0 if we can. It's a pretty easy medicine to take. It's not going to harm anything. So, honestly, maybe if your doctor's uncomfortable with it, but you are comfortable with it, maybe it's just not something that you even really have to discuss too much. Now, what can it do? It does block opiate receptors. So we usually stop it before your egg retrieval. Why is that? Because you're going to be getting some pain medication with your egg retrieval, right? We don't want to be blocking those receptors so that you can get some pain medicine that does your job. So, but I would feel pretty comfortable with LDN. Special hello to Kayla Thompson. Thank you for being here. Lovely Onyx, what causes leg cramps in early pregnancy and what can be used to help? Also, what causes cramping in early pregnancy, waking up, and what can be done to help with that? So, half of normal pregnancies will have some cramping and bleeding in the first trimester. So it's not unusual there, Onyx, to have some bleeding as well. So lots of different things can cause you to be crampy. One of those things is that your bladder may be full and you're getting up in the morning, your bladder is full. Remember, your bladder sits right on top of the uterus. And if it's pushing down on the uterus, you may end up having some cramps or contractions that you're just kind of more aware of when the uterus is small and it starts to grow. As for leg cramps, the it is it's said to be multifactorial, that it can be, I've heard people say it's calcium, so you should eat some extra calcium. I've heard people say it's potassium, so you should eat a banana every day. I tell you the one thing that when I was practicing obstetrics, because leg cramps are one of those things that I wish I could tell you they will completely go away, but they may not. You may continue to have them. What ultimately will make them disappear? You take a little glass is all you need, of tonic water. Like you were going to have a vodka and tonic or a gin and tonic, skip the alcohol, just have the tonic over ice. It's kind of sweet. It has a pretty distinctive flavor. You'll learn to drink it. You don't need a big glass of it. In fact, that may make you barf. But a little glass, tonic water, cold tonic water over ice. What it has in it is a chemical called quinine, and that will make your leg cramps go away absolutely, generally completely. So let's see. Rosa SD says, I have an AMH of 0.1. So that is a lower ovarian reserve. Will my ovaries go to menopause after being suppressed with Orilissa? The plan is for 2 months of Orilissa and a modified natural FET. Concerned that my ovaries will not respond. So what the medications for endometriosis do is that they turn down the volume knob on endometriosis. They make the communication between brain and uterus a little clearer by decreasing the endometriosis receiving of that signal. There is no evidence to say that using these medications will push you any closer to menopause. In fact, Rosa, here's a common question. I've actually heard it 3 times today. Well, my AMH is low. So in your case, your AMH is 0.1. Does that mean that I am going to go into an early menopause? And the answer is no. So you still have hundreds of thousands of eggs, most likely, in your ovaries there. What it tells me is that it's going to be harder for us to give you medication to get you to produce those eggs. Now, if you are, I don't know how old you are, if you're 48 years old, then yeah, menopause is coming down the pike for you. The average age for menopause in the United States is 51.4. So if you're 48, you're definitely getting closer. If you're 34 with an AMH of 0.1, well, you have a low ovarian reserve for your age, but that does not mean that you're going to be having a premature menopause. Now, if you use Lupron, the Lupron medication to suppress your endometriosis, that will put you into a temporary menopause, but it's temporary. Your ovaries will recover from that unless you're just about to go into menopause anyway. So it kind of depends on, really what your age is. But you don't have to worry that suppressing endometriosis is going to result in a premature menopause for you. Okay. Important to know, but also a really good question. Hi to Brooke Weisner. I had a failed FET. Let's not call it failed. Let's say it was an unsuccessful FET. And I don't mean, it's not just mincing words there, because to be honest with you, every time we do something in IVF, every time we do a cycle, whether it's a transfer cycle or a stimulation cycle, we are always learning something. We are always going to get something from you that can be used and applied to later on, so that we may know something more to help you the next time. So not failed, just unsuccessful. I transferred 2 euploid embryos, okay, and was on Prograf. I had a hysteroscopy the month prior to remove a fibroid. We only have 1 embryo left. Recommendations. Well, so Brooke, in that situation, putting in 2 euploid embryos goes against the guidelines. It creates a potentially hostile environment inside the uterus, and does not increase your chance for a live birth. So I wouldn't have recommended that. Why didn't it work? Well, could have been from anything. Sounds like you did everything right. You were on the correct amount of Prograf. Your your lining was normal. You'd had a hysteroscopy. It just may not have been your time. However, now that we're going to get to the next embryo, which would be your 3rd euploid embryo, you're at a 95% probability of pregnancy, even if you don't do anything different. So what I usually think about in that scenario is, well, if you did a medicated cycle, maybe we switch to a modified natural cycle. And I am a fan of the modified natural, or what we call an ovulatory cycle. What the hell is the difference? Well, medicated cycles, right, have been around since IVF was invented. When you put an embryo back in, the thinking was, well, we need to give you all that hormone. We need to control everything. We need to be in charge of every variable. And so we're going to give you all these synthetic hormones coming from the outside. Well, the fact is, and that's, still, I think 75% of the embryo transfer cycles in the United States are medicated cycles for that reason. That's the one that involves the progesterone in oil shot. Wah, wah. Occasionally I run into somebody who says, I don't mind the shot so much, but most people, common things being common, would say, not my favorite thing to do. Not my favorite thing to do. And I get that. It's a big needle. It goes in your butt. It's a big thick liquid. It goes in the muscle. It makes big knots in the muscle. It can give you bruises. I know people whose poor little butts are still bruised from PIO shots last October. So, it's not delightful, right? The modified natural is where we give you some letrozole, or a natural is where your body is going to create a follicle. It's going to grow that follicle, which makes your own estrogen. You're going to ovulate that follicle, or we will trigger the ovulation, which tells the ovary to release the egg. And when you release the egg, you make your own progesterone. So you are using your own hormone. So we say natural. Sometimes people say, I'm a little leery about that. It does not mean that we put an embryo in and say, call us when you have a birthday party. All right. It means that we're still monitoring everything that's going on with that cycle, all those hormone levels. It means, we're still looking at everything with the ultrasound. We're still doing the checking the hormones. So if we need to give you more hormone, we'll give you more hormone. But the hormone is principally coming from you as a result of ovulation instead of coming from a pharmaceutical. So those two things are said to at least be equivalent. And there are some studies that show the natural or modified natural to have a little higher pregnancy rate, a lower miscarriage rate, and a lower risk for certain ongoing pregnancy complications. So I'm a fan of the natural cycle if you can do it. There are some times that you can't, that it just doesn't work. If you don't have a normal period, if we can't get you to have a period, if your lining never gets thick enough, if there's all kinds of different variables there. So talk to us about that if there's a question. But anyway, Brooke, so I would think about maybe shift gears, maybe try a different type of cycle. But otherwise, I think you did everything right there. Although I would recommend one euploid embryo to follow the guidelines, because those guidelines are designed to get you one healthy baby at a time. So it looks like Ninax 3 Bella. Can't wait for my consult next month. We can't wait for you, my friend, and maybe I can say your name right by then. Morgan Lynn Hunt. Hi, first modified natural. FET was unsuccessful with good lining and levels. Should I change my protocol or try one more FET? I would say try another FET because, again, when you can do a cycle, when you can do an FET and it works the first time, quite honestly, it's lucky. And I don't mean that in any bad way at all, but statistically, IVF is a numbers game. It's about making enough embryos so that one of them is going to be normal and it will stick. And so any one embryo may not stick, and that's not an abnormal finding. Just like we don't get pregnant every time we have sex, we are sometimes sperm is fertilizing eggs and making an embryo that just isn't able to stick. So it is not a normal thing that every embryo will stick. It is much, much, much more common that embryos don't stick. So Morgan, I don't want you to think that something is wrong with you because the first one didn't work. The odds are probably pretty good that you've got an embryo there that's going to get you pregnant. So I would stick with the modified natural. I do think that is a cleaner and better way to cycle. Again, not knowing anything else about you, then I would say, that's what I would do. Rose is asking, is Prograf safe for an embryo? Yes, it is. It is used in pregnancy for women who have had organ transplants and is pretty well studied. M. Dowdy says, waiting for cycle day 1 in order to start stems, traveling from Tulsa, Oklahoma. Fantastic. Does an ovarian endometrioma without any pain symptoms need to be operated on? So here's the thing about an endometrioma. By the way, I will say if you've just joined us, it's 38 minutes after the hour, and we're going to be here for about another 20 minutes or so. Fertility with Fink and Friends. I am Fink. You are Friends, and it is so nice to be here with my friends every Tuesday. So thank you so much for being here and letting me share my voice with you, and you share your love with me. Thank you. Endometrioma. So if you operate on an endometrioma, you will decrease your ovarian reserve. That's really just a fact, and it happens almost every time. So you don't necessarily need to operate on it unless it's causing you symptoms. Now, once things start to get to be about 5 centimeters, we start thinking, well, we run the risk for them twisting, which is called an ovarian torsion. And that's not a good thing. And you're calling it 4.7, it may be time to operate on it. But from an IVF standpoint, we generally can work our way around an endometrioma in order to retrieve the eggs. The endometrioma can take up some space, which can occupy good real estate that the eggs want to use to grow. So it's an iffy situation there, but I can say that if you do have surgery on it, your AMH level will go down. Let's see here. Neri says, I am 42 years old on immune protocol 2, doing my first modified natural frozen embryo transfer. Would like to know how important it is to take all those immune meds. Well, here's the thing about the immune situation. There's icing and there's cake. All right. The cake is the estrogen and the progesterone. Where are you getting your estrogen and progesterone? If it's a medicated cycle, you're getting estradiol tablets that are vaginally and orally, and you're getting progesterone in oil and some progesterone vaginally. If you're doing a natural cycle, then you're making that yourself. We're giving you a little bit of supplement. So that's the cake. Where's the estrogen and progesterone coming from? The icing is, well, what are we doing about the immune system? Can you eat cake without icing? Of course you can. There are some very good cakes that don't have icing. Pound cake, for instance. Devil's food cake. Who doesn't like devil's food cake? Personally speaking, I prefer cake with icing. I like a nice bundt cake. Have you had those nothing bundt cakes? Those are wonderful, especially the red velvet. Yeah, I think I know what I'm going to do when I'm on my way home tonight. Now that you brought it up, and it was you that brought it up, right? So you can have cake without icing, and that's the estrogen and progesterone. There are many practices that don't do anything at all with an immune protocol. The question is, well, are these immune protocols helpful in the general population? Well, we know that people, this is not really a general population. This is a fertility population. So the immune system is going to be involved on some level. So we add the immune protocols, and typically immune protocol 2 is the basic one that we use for IVF and for embryo transfer. It includes some prednisone, some blood thinner. I recommend Lovenox, or rather, I recommend Diprograph, like we just talked about. Lovenox is the blood thinner, some antihistamines, an HCG wash, sometimes in a natural cycle, an HCG booster. So, these are basic kind of things, but they are voluntary, just like eating the icing is voluntary. You can get a big old slice of cake that's full of icing and leave the icing on the plate. You don't have to eat it. It's just our recommendation. And so, I think it does make sense in many cases to add some immune things there, because the immune system is definitely involved in keeping people from getting pregnant. So that's the story there, Neri. Now, my guess is that at 42 with your own eggs, the issue is likely more going to be one of the egg that made that embryo. So is something, if not using that immune protocol, fail to get you pregnant? If you don't get pregnant, it is not likely because of the immune protocol that you used or didn't. It is more likely in your situation because of the embryo itself and the stability of the DNA. Was it a normal egg? Did it make a normal embryo? At 42, that's a much bigger consideration than something in the immune system. So hopefully that is helpful. Hi to Star Ray. My first beta is tomorrow. My day 3 transfer was on May the 4th. Our fingers are crossed for you, and I will keep my eyes out for that positive result. Yeah. Hi to Jessica Huffman. I just had my first unsuccessful FET with a perfect 5-day blast. Would you be against transferring 2 untested embryos for FET number 2? So in that scenario, Jessica, and I would say no. I think that is probably fine because that has been studied. We recommend 1 for the first transfer. If it's unsuccessful, it's not unreasonable to consider 2. Now, it may still be outside the guidelines because if I remember correctly, you are young, and the younger we are, the greater the probability that those eggs are going to stick. And we, again, really don't want you to have twins or multiples, but yes, you can do 2, Jess, for sure. Lindsay asks, my first FET ended in a miscarriage before 5 weeks. I am so sorry to hear that. So with that said, would you continue with the same protocol, which was natural? My progesterone, it transfers 21, and at midway it dropped to 14. My first beta was at a 10. We also plan to do the HCG wash. Would this help my next transfer? Just want to make sure I'm doing everything I can. Have added acupuncture and chiropractic. So in most circumstances there, Lindsay, what you described there with a beta HCG of being 10 is what we would call a biochemical pregnancy, that the pregnancy started to take hold, but then wasn't able to continue growing. When that happens one time, that is usually considered to be because of an embryo issue or a chromosomal issue, something genetic with the embryo itself. So there is nothing about the protocol there that I would necessarily change, although there is some evidence to say that using a modified natural instead of a natural, that is to say that, yeah, you ovulated on your own, but if we give you some ovulation induction with letrozole for 5 days, we may have some more positive effect on the uterine lining, which may decrease miscarriage rate. So I might try a modified natural in that situation. Your progesterone was all pretty good there. In a natural, we just want it to be above a 10. So I think it probably really had more to do with the embryo, unfortunately. But we all stand with you in your loss and know that there will for sure be happier times ahead. Tori is with us, tested positive day 4 after transfer. I have a beta tomorrow. What does graduating from CNY look like? Well, usually it's about 7 weeks or so, sometimes 7 to 8 weeks. And we say, okay, you are free to go and see your OB. So usually, each week we will have you do an ultrasound so that we can continue to see the heartbeat, know that that pregnancy is viable. Once you look and you see a heartbeat, we know that 95% of those pregnancies will continue on. Without having a problem. And that is just great odds. Once you are past the 12-week mark, that number goes up to 99% that the pregnancy loss rate is about 1% after that. So looking and seeing the heartbeat, Tori, is probably the best thing that we can hope for. And going off to your OB means that you establish obstetrics care. They'll usually do an initial examination and a bunch of blood tests if you hadn't had them done. If you've just gone through IVF, you've already had most of them done. They may require you to repeat, a couple of different things. And ongoing obstetric care. So that is very exciting news. Let's see. We've got Christina is with us. After you do suppression for 2 months, do you have to wait for cycle day 1 to come before transfer? Typically, can you travel after transfer? Yes. So when you're coming to one of our facilities for transfer, I generally recommend you get here the day before, because I like to see people doing the lipid infusion. I like the HCG wash. I do think those are good things. Those you do 1 to 2 days before the transfer. Plus, you don't really want to be traveling on the morning of transfer because it's just so stressful and getting through security and the flight being delayed and then the weather and the flight attendant's rude and, whatever happens to you, somebody screams at you and somebody's naked on the plane, and the next thing you know, you're on the news. And avoid all that. Travel a little early. Get here the day before if you can. You can do your transfer, and yes, you can go home that later on in the day of your transfer. I generally tell people we like you to be taking it easy for 2 days. What does that mean? You can live a normal life. You can walk. We do not want you to be on bed rest. I just say no, bungee jumping, no alligator wrestling, no cage fighting, extreme snowboarding, helicopter skiing, that kind of thing. Resume those things in a couple of days, but 2 days, take it easy. If you're going to be traveling, don't carry your steamer trunk on your back. Make it an easy thing to the best of your ability. So yes, you can travel. So you finish off your suppression, and then really you can, it just depends on kind of what's going on in your lining. We want your lining to be thin. Some people will get a period, but really you can also just kind of, if you're doing a medicated cycle, you can just start on some estrogen, start building that lining up. Or you can also, doing a modified natural, go right into your letrozole for ovulation induction. Now, what I don't recommend is that you try to do a completely natural cycle after suppression, because your body may be a little slow moving. It may be a little slower to respond in the natural hormone way. So it's just a little more reliable to either do medicated or modified natural. Looks like VAABX. My last two FETs were not successful. Both were medicated. Dr. Abay recommended another medicated cycle with extra PIO. Should I do another medicated cycle or change to a modified natural? Extra PIO. Well, so the situations where I've recommended that are in folks who have had a hard time getting their progesterone to be high enough. So, that is something that we test. If your progesterone level is not high enough, then I would give you more PIO. But I think it's certainly reasonable to say, hey, let's shift gears and try something different. A modified natural sounds like a reasonable thing to do. Sue Allegiant, I think that says. I did PRP in January. Will that still benefit me when I go into having an embryo transfer in July? Well, we don't, 100% know the answer to that. How long does the effect last? I think it probably at least lasts for 3 months. It may last for 6 months. So you did it in January. Here we are in May. I would say, probably realistically, the effect is starting to wear off. But again, hard to say for sure. Let's see. LA08, my first transfer just failed. I have 2 poorly graded embryos left. Should I just jump into another transfer or do additional testing and change the protocol? Well, if it was your first transfer, again, I would not say, oh, that means, something's wrong and you have to do all these things now because your first transfer didn't work. First transfers just don't always work. In fact, any transfers may not work. Eventually, one will probably work. But will it be that first one? Well, if it's a euploid embryo, 65% chance. Hey, that's pretty good, but it's still not 100%. And that's the best we can offer in IVF. So, I would consider, I always think, and we were just sort of really having this conversation today, Brandis and I here, that people often lose sight of the bigger picture. And that is they want so much to be pregnant right now that they sometimes forget, well, gosh, we really, we're hoping to have, in our dream, we want to have 3 kids. Well, if that's the case, don't do a retrieval and go right into transfer. Maybe, bank up as many embryos as you can. And, thank heavens, fortunately here at CNY, I mean, it's still an expensive process, but, you can do, probably 5 cycles of IVF here for what it might cost to do 1 cycle for you at home. If we're able to bank as many embryos as we can, then we know that down the line, we're going to be in a better situation to kind of get pregnant. I don't know if you can hear it, but I think it's hailing outside, and it sounds like all the cicadas are, the whole swarm is smashing into the window here. Actually, Colorado, I'm told, doesn't have the cicadas, so we will not have to deal with them. But if you're hearing a little strange noise on the outside, it's because I think a big rainstorm just came through, and I think we're getting a little hail. I lost my train of thought there, Leah, but yeah, I would keep going with your transfers. Now, here's the caveat there. How many kids do you want to have? And if you tell me, and I think I know what your answer would be. I don't know you, but I think I know your answer might be, well, we would really just at this point be happy with 1. But, in our hearts, we wanted 2, we wanted 3. I get it. Well, let's say that we did a transfer and you got pregnant from that transfer. It's realistically going to be another 1.5 years or something before you can do another retrieval to make more eggs and make more embryos. And the difference in egg quality between now and 1.5 years or 2 years from now is probably going to be substantial. And that's really based on, how old you are, but there's going to be a difference between now and 2 years from now. So I would always say if what you're hoping for is a bunch of kids, then I think you're better off doing your cycles. In fact, do them back to back if you can, because we get sequentially better results with each stacked cycle. Uh, do these cycles, bank up your embryos, and then think about doing your transfers. Let's see what else we got going on here. Lots of nice folks. Do you suggest taking Serovital for egg retrieval? No, I do not. And the reason for that is that Serovital, which is a supplement that is said to improve, to increase growth hormone rates. Growth hormone is helpful for egg quality. However, Serovital has never been studied in pregnancy, and one of its main ingredients is an amino acid that's called L-arginine. And what we talked about a little bit ago was that L-arginine is not recommended for egg quality. Why not? It creates chaotic and dysynchronous growth of follicles or of eggs in the ovaries. It worsens egg quality. So we don't know about Serovital in pregnancy. We know it's supposed to increase growth hormone. Is the way it increases growth hormone, does that surpass its negative effect on egg quality? It's never been studied. What has been studied is that L-arginine in a supplement form is not good for egg quality. So therefore, no, I absolutely do not recommend Serovital for egg retrieval. Let's see here. I know we had some other little questions. Testing is Monday. That comes from Golden Prinny. Can you do a hysteroscopy and a laparoscopy for endometriosis and an egg retrieval all at once, or should they be done at different times? This comes from Vicki Rowland on CNY's Instagram here. The laparoscopy is done at a different time. Laparoscopy is not done for egg retrieval. We don't really want to be putting a scope or sharp implements inside the pelvis when the ovaries are that large. So given that, I would say if you're going to do a laparoscopy, and again, I don't recommend laparoscopy strictly for fertility purposes, but if you're going to do a laparoscopy anyway, do your hysteroscopy at the same time, done in the beginning of the cycle. Now, there are many people who will evaluate their uterine cavity with a hysteroscopy at the time of egg retrieval. We do that here in Colorado. They will do that in Syracuse. They will do that in Sarasota. They do not do that in Albany, and I am not so sure about Dr. Cheng in Rochester. I should ask him about that. But I would say, yeah, but if you're going to do a laparoscopy anyway, do your hysteroscopy at an earlier in your cycle. Zulinka is 31 weeks, thanks to Dr. Fink and CNY. Awesome. Thank you for sharing that, my friend. Oh, it makes me so happy to hear. Hi, Faith. For those percentages, is that for everyone or is that just for normal embryos? So if we were talking about, when you talk about the percentages, 65% probability of pregnancy with the first embryo. These are with tested euploid blastocysts. 65% with the first, 88% by the time you do embryo number 2, and 95% by the time you get to embryo number 3. We got a couple of minutes left. Let's see if we can throw in some last minute questions. For someone who's just starting with CNY for IVF, start to finish, what's the time frame? Well, IVF, so, the initial thing is just, getting the consult. That takes a while because of the number of people who are trying to avail themselves of the CNY price point, which frankly is the lowest cost IVF in the country. So it takes a little while to kind of get over that fence and to get that initial consultation. We then do a diagnostic month where we're collecting the blood tests, the semen analysis, doing some of the preliminary testing. Once that's done, you can start IVF with your next cycle. So let's say you get your period on cycle day 1. Typically by day 14, you're done with stimulation and retrieval. So it's just like in a natural cycle where you might ovulate, produce an egg, or you produce an egg, a follicle grows, and you ovulate. Well, that all takes place within the first couple of weeks. What you do with the embryo after that is some variables. So if you're going to do a fresh transfer, it's anywhere from 3 to 5 days after your egg retrieval. Otherwise, you would freeze your embryos and you come back another time to do the cycle. So if the question is really kind of what's the time frame start to finish, if you're actually talking about the stimulation part of IVF, it's really just a couple of weeks. Let's see here. Isha says, I'm in Mississippi. What state is closest for me to get IVF? I would say that's probably in the Sarasota location there. Isha Love. Nicole Baum asks, how do you feel about a patient electing to do IVF as natural as possible? I have a family history of breast cancer, so I'm leery of hormones. I don't want to take any if possible. So there is such a thing that's called natural, and so there is no evidence that ovarian stimulation increases the risk of cancer. In fact, the hormone levels associated with pregnancy are significantly higher than anything you'll get during the IVF process in all probability. So I don't think you have to worry, but there is something that's called natural cycle IVF. And in your natural cycle, you produce typically one follicle. So we can go through the process, retrieve your one follicle, which hopefully will give us one egg, which hopefully will give us one embryo, which hopefully will give us one baby. The problem is it's expensive to do for a single follicle, and the price is the same whether you're using medications or not. Now, the medication cost is obviously is extra, but yeah, there's definitely natural cycle IVF, and that is something that you can do. Ashley says, "What are your thoughts about an HCG wash?" I think it's a good idea. It turns up the receptors for pregnancy in that uterine lining because it's the pregnancy hormone. So, yeah. Allie says, thank you, Dr. Fink. You make me feel so much better. His queen asked, his queen lovingly Keith, like the name, can I choose the sex of the embryos? Yes, that's called gender selection or sex selection. And that is done through the process of PGTA, pre-implantation genetic testing for aneuploidy. We are all out of time for this Tuesday afternoon, friends, but we'll be back next Tuesday as always, and I hope you will be as well. Every single day, I try to take every step forward with kindness, because the world is not a kind enough place, and I encourage you, be kind to your friends, be kind to your neighbors, be kind to those who you don't know around you, because you don't know what's happened in their day. And that one random act of kindness can make all the difference in somebody's life. Lead forward with love, and each day is a new day of hope. And that's what I started to say there before. Tomorrow is a new day full of all new possibilities. So don't give up, knowing that the sun will rise again tomorrow. My name is Dr. Randy Fink, and every Tuesday night we're here, Fertility with Fink and Friends. This is not the novel of your life. This is merely a chapter. And what we're here to do is to help you rewrite it. So until next week, thanks again so much for being here, and good night.